I have been given the privilege of talking about pulmonary function tests, and I will try and stick only to evidence-based medicine. So everything that I talk will be from the guidelines. So the reality, the most important thing when you're considering therapy for lung cancer is to have a live patient. And that's the most important thing, no matter what you do. So it's mandatory to assess the risk, to balance risks versus benefits, and offer surgery or any therapy on the basis that benefits outweigh the risks. That's absolutely, this should be the bottom line of treatment. As surgeons and physicians, we like to be brave. We like to push the boundaries, but it is important for us to remember, all of us to remember, that the risk is actually being taken by the patient and not by the treating doctor. Hence, it is very important to follow the guidelines and very important to follow the, the recommendations of the various societies. The two papers which I'm going to refer to today are going to be the ERS, ESTS clinical guidelines for fitness for radical therapy. And I'm also going to talk about the ACCP evaluation for patients with lung cancer being considered for resection surgery. So everything that I speak today will try and relate to these two papers and will give some guidelines for our candidates, for our participants to follow treatment. The two guidelines have actually come up with a fantastic flow chart of management. And if you do not read the whole paper, if the flow chart is the only thing that you keep with you, I think the purpose of my lecture will be well served. The one important point I want to make is in both the charts, before the pulmonology evaluation comes the cardiac evaluation. And that is why when we were discussing the case in the last session, it was very important that you should not really do pulmonology evaluation first. You must do the cardiac evaluation first before you get on to evaluating a patient for treatment with lung cancer. So both the guidelines talk about cardiac evaluation followed by pulmonology evaluation. And the evidence that I will present to you is based on the Scottish Intercollegiate Guidelines Network. So I will be giving you evidence of 1, 2, 3, and 4 with a plus added to it. And the recommendations will be based on the basic pulmonary function tests that we all get involved with are a standard spirometry with FEV1 and FVC. We also look at flow volume loops to understand whether the patient has obstructive or restrictive disease. If you want additional information, you can add whole body plethysmography to look at lung capacities and lung volumes. And all of this will give you a baseline idea of how good is the function of the lung in this patient with a diagnosis of lung cancer. But before you consider any surgical treatment or oncological treatment, it is mandatory for you to perform a DLCO. That is part of the guidelines, and I'll go into that in a bit more detail. And you must actually know what is the DLCO for these patients. So what do the guidelines talk about spirometry? They clearly state that spirometry should be performed on all patients diagnosed with lung cancer. Predicted postoperative FEV1 should not be used alone to select a patient for lung cancer surgery. They've very, very clearly said this. You have to have a DLCO and a postoperative predicted DLCO. If you just look at the spirometry, a predicted postoperative FEV1 of less than 30% is a high risk for surgery. As bottom line, remember this number, less than 30% is high risk for surgery. And prediction of postoperative PFTs is recommended by the guidelines. And the level of evidence is 2. So this is quite a decent level of evidence. So please do not do any lung cancer work or treatment without looking at spirometry and basic levels of the function of the lung. What is the recommendation for DLCO and predicted postoperative DLCO? DLCO should be used regardless of spirometry. So no matter what the numbers are, you must have an additional study of DLCO. It is not acceptable medico-legally to actually treat a patient with lung cancer without a number of DLCO, because if it goes to court, you will not be able to stand up clearly in court. A predicted postoperative DLCO of less than 30% is high risk for surgery. So 30% DLCO and 30% FEV1 predicted post-operative are the two cutoff numbers you must remember, and you must really worry about offering them surgery or other treatment. Again, the level of evidence is pretty decent, 2++, and a level of recommendation of B. What about segment counting? Do we need to know about the segments? Yes. Residual function, the predicted post-operative residual function should be based on segment counting of the lung. So you must know the segmental anatomy. But more importantly, when you want to predict the post-operative function, you have to look only at the segments that are not obstructed, which means the segments which are participating in the respiratory function preoperatively. Those are the ones that have to be used in the calculations for post-operative prediction. A borderline, if the patient's lung function is borderline, then an image-based calculation of the residual lung function is recommended by the ESTS. And that means ventilation or perfusion scintigraphy, particularly when you're talking about pneumonectomy. No patient with pneumonectomy should actually have surgery without a ventilation or perfusion scintigraphy. Of course, if his FEV1 is more than 2 and DLCO is more than 60%, then that's different. But otherwise, anything less than that, you must have a VQ scan. A quantitative CT scan is recommended before lobectomy or pneumonectomy. And again, the level of evidence is 2+ and B. The recommendation is B. So this is how you must know the anatomy of the bronchopulmonary segments. You must remember which are the obstructed, which are the non-obstructed segments. And this is the formula for calculating the predicted post-operative values. Now, I won't go into details of this. This is all available on the net and you can work it out. So it's a preoperative FEV1 into 1 minus proportion of the lung to be resected. Or if you're using the segments, then it's 19 minus the segments to be removed divided by 19. So this is a formula that we use all the time. If you've got obstructed areas, then you have to remove that from the calculation. So only the well-aerated areas are the ones that are used in the predicted post-operative calculation. So it is very important to calculate the pre and the post-operative FEV1 and DLCO. Okay. Ventilation perfusion, what does the evidence say? The evidence clearly states that ventilation perfusion scintigraphy is a good predictor of post-operative lung function. But you don't need to do both. Only one is enough to give you a good indication of what's happening, what's going to happen to the patient in the long term. FEV1, DLCO, and VO2 max have been included in the algorithm. And I'll talk about these in a bit more detail. If you want to do some research, quantitative CT, MRI, and SPECT scan are the new tools that are available for understanding lung function. So these are still in the research domains. So once you have done the basic lung function test, what is next? The next step that you have is exercise tests. The exercise tests are indicated in patients undergoing lung cancer whenever the FEV1 or DLCO is less than 80%. Now, this is the ESTS guideline. If you look at the ACCP guidelines, they talk of less than 60%. So it doesn't matter whichever one that you're following, just follow one guideline and stick to it. Again, the level of evidence is quite high. So you must investigate a patient further if your predicted FEV1 or DLCO is less than 80%. What is the role of shuttle walk test in this? The role of shuttle walk suggests, the literature suggests that actually shuttle walk underestimates exercise capacity and should not be used alone. It should be used in conjunction with one of the other tests, which I'm just about to talk about. So don't use just a shuttle walk to decide that your patient is fit for surgery. Stair climbing is a very, very sensitive test. Stair climbing, you have to reach a height of about 22 meters. So it depends on whatever is the level of stairs. At least 2 floors is what we do in our traditional hospitals, but 22 meters is the recommendation. It's a cost-effective tool which accurately predicts morbidity and mortality in the post-operative period. And it is better than spirometry and first-line tests. So in my clinic, I will always send the patient up and down the stairs, or I will walk with the patient up and down the stairs, and that gives me a good idea about whether this patient can undergo surgery or does he need to undergo further investigations with regards to CPET. The one thing that you have to look at stair climbing is not just the ability of the patient to climb up and down, but also the oxygen drop after the stair climbing. So the 4%, you put in the pulse oximeter, and a 4% drop is what is calculated. And if the calculation is more than a 4% drop, you're dealing with a patient who's likely to have higher morbidity and mortality and needs a formal CPET to be assessed. 6-minute walk test is actually not well supported in literature. And in fact, the guidelines say the 6-minute walk test should not be used to select patients for surgery. So a stair climbing is very good. So pyrometry, a DLCO, stair climbing. And then if you're worried about any of that, then you move to the next step, and that is CPET. Where do you use CPET? Well, in CPET, what you're really calculating is the VO2 max. And 3 numbers have to be remembered. One is more than 20 ml per kg per minute, which is low risk. The second one is more than 12 ml per kg per minute, but stopping at 20, that's a moderate risk. And the third number is less than 10 ml per kg per minute. Always get worried when the number is less than 10 ml per kg per minute. This is a high-risk candidate for surgery, and you should not consider him for surgery. He will end up with serious morbidity and mortality. And then using the VO2 max, you can also calculate a predicted post-operative VO2 max. So what is the recommendation of the guidelines? They say that VO2 peak should be done on the treadmill. It's highly predictive of post-operative complications. Very important. So VO2 is a good tool to use. They say that more than 75% or more than 20 ml, a guy is fit for a pneumonectomy. If it is less than 35% or less than 10, as I said earlier, he is too high a risk. But there is not even enough evidence on VO2 and CPET in literature as to what should be the value for a lobectomy. So always try to, it's the worry is the pneumonectomy patients, whether they will tolerate pneumonectomy or not. So work these numbers depending upon whatever you've got with your patients. Of course, they talk about future trends in terms of exercise DLCO, which could be a complement to the test. What is the operative rehabilitation according to the guidelines? Smoking cessation 2 to 4 weeks before surgery, highly recommended. Level of recommendation is B. Early pre-op and post-op rehabilitation, recommended level of evidence 2+. And pre-op exercise is inversely proportional to morbidity. So very important to work these patients up towards surgery or chemotherapy or radiotherapy. Do not rush into it. The scoring systems are not well evaluated, and I don't think we need to do that. There is also talk about need for ICU in these patients, and routine admission to ICU after surgery is not indicated. Only marginal cardiopulmonary reserve or moderate to high risk should be looked for surgery. What about quality of life? Quality of life should be used as a modality of tool. Simply PFT is not a good predictor of perceived quality of life. It is the perception of symptoms which is important for quality of life post-surgery or post-chemotherapy. So a quality of life tool must be used in analyzing these patients. What about patients with cancer surgery and LVRS? You can actually do anatomical lobectomy plus LVRS in well-selected cases. And what about anatomical segmentectomy? Now, these are the guidelines 2014, but they are being updated all the time. But the last guideline was 2014. They speak about anatomical segmentectomy in a stage 1A tumor, less than 2 to 3 centimeters, with a margin of resection more than 1 centimeters. Stage 1 in a poor PFT, lung resection after prior lobectomy, a wedge resection, or a stage 1 less than 2 centimeters. So the level of recommendation is D. So we're still not enough data to actually come up to a level of recommendation of B or A. But now the data is coming through, and I think once these recommendations change, anatomical segmentectomy will become the mainstay of treatment in patients with compromised lung functions.